Before we treat somebody for dementia and say, oh, okay, yeah, this person has a dementing illness, it is really important to make sure that depression is not part of the picture. Depression may present itself in different ways than it would present itself in a younger person, for example. And when you add an antidepressant medication on top of a cholinesterase inhibitor, you need to have that awareness that. Welcome, everyone, to the Dementia Doc podcast. I am Dr. Miguel Rivera, and I am joined by my wife, Ganga. And today we're going to talk about depression and dementia.
Miguel, what are the specific difficulties with depression in dementia?
Well, I think the most obvious one is that so many times people with dementia have difficulty communicating, so they may not really be able to tell us, I am feeling depressed or I am feeling anxious, or to be able to verbalize how they feel. The other aspect is that, the depression may present itself in different ways than it would present itself in a younger person, for example.
Before we discuss how you diagnose depression and dementia, why is it important to detect depression? How does it affect your patients?
Good question. Depression is like a bad actor. Everywhere that it goes, it makes things worse. So, depression makes cognition worse. So it can affect memory, it can affect, speech, it can affect other different cognitive functions. Depression can also make other conditions, for example, physical conditions like pain. So somebody who is depressed may have a more, let's say, significant response to the pain and may actually feel worse because they're depressed.
I would think this is true also about people who do not have cognitive decline, but it almost compounds in people with dementia. So if you say depression makes cognition worse, then if a person is experiencing cognitive decline, then depression would make it even worse.
Yes, and that is actually a good point. And that is that sometimes depression can present as dementia. So in addition to making cognitive problems that are already there worse, it can actually present itself as dementia. And this is something that we call pseudo-dementia or false dementia. This is why it's so important that before we treat somebody for dementia and say, oh, okay, yeah, this person has a dementing illness, it is really important to make sure that depression is not part of the picture.
But I think you're pointing to this almost a whole separate topic of aging, cognitive decline, depression, and pseudo-dementia. I think we can have a whole discussion for 30 minutes on just that. But if you bring it back to people who do have dementia, the beginning stages or later stages, then what does depression do to them? How many of your patients today experience depression?
Quite a few. I would say that between 40 to 50% of my patients with moderate to severe dementia are also experiencing symptoms of depression.
And how do you detect that? Or what's the process? You see patient, and how do you know, let's say it's not just a progression of dementia, that they may not focus well, the cognitive function is declining. How do you differentiate that it's not just dementia progressing, but it's depression at play?
So let's say that the person is at their typical level of functioning, like they have, like in my patients, the more moderate to severe range of dementia symptoms. And then all of a sudden there is a change. So something is different, right? So what is important is to, number one, rule out delirium. make sure that the change is not actually due to some medical condition, like, for example, a urinary tract infection, or that they're taking an anticholinergic drug that is making them worse, or that they're having a pneumonia, or, so to rule out the medical causes for the decline is really important. Once the delirium or the acute change in mental status has been ruled out, then we can say, okay, is this depression? And so, for example, when I'm first evaluating somebody for depression in dementia, I always want to look for collateral information. So I will call the family and say, hey, have you noticed anything different in your loved one? Do you think that their mood, for example, is worse, that they're a little bit more anxious, that they're more irritable or agitated? And also to talk to the staff from the facility or to the caregivers if they're at home, because the collateral source of information can provide some important details that you would not normally get if you're just interviewing the person.
Mm. Yeah, as you pointed at the beginning, one of the difficulties that I guess people with dementia cannot really communicate clearly to you, hey, I think I'm getting depressed.
Yes, and so those communication issues are part of what makes this diagnosis worse. I would say that of the majority of the patients that I have with dementia, um, very, very few, 5%, told me I am not feeling good. They were having either a change in their behavior, acting more anxious, maybe isolating, social withdrawal, not participating in activities. Like I mentioned, having a worsening of their chronic medical conditions, like pain, for example. Or, I saw a patient last week that the reason why they asked me to see her was because she was complaining of being more short of breath. And after examining her and talking to family, what the family told me that it wasn't just a complaint of the shorter breath, but she was complaining of knee pain and shoulder pain and pain in general. Where do you hurt? I hurt everywhere. Where is your particular pain? She couldn't actually pinpoint it. So, that is something that I see commonly. It's that the depression is actually presenting itself with symptoms other than sadness, or let's say loss of enjoyment, which is another one of the main symptoms, of depression. The inability of the person to enjoy the things that they previously enjoyed, something that we call anhedonia.
That is fascinating because to think that someone is in pain and the reason for that is nothing really typically neurological or whatever the causes of pain, but depression. So when you discover that, what is the cause of treatment? What can you do for these patients?
So there are two main camps, let's say. There's the non-pharmacologic, meaning non-medication intervention, and then there's the medication route. So I always try to encourage the non-pharmacologic approach first, because of things that we will discuss. But obviously, psychiatric medicines can have drug interactions and they can lead to falls, etc. So even though I use them a lot, but I try to not let them be my knee-jerk reaction, that, oh, the person is depressed, let's put them on an antidepressant. So, what are some examples of non pharmacologic things that we can do? Well, for example, then things like addressing their sleep. So, helping people sleep better is a big one. As people progress along the path of dementia, many times they have circadian rhythm disruption. That's a fancy word for meaning that they are up at night and sleeping during the day. And that can make so many things go awry. because we're supposed to sleep at night and be awake during the day. So I tend to prescribe sunshine and fresh air. So to have the facility or the loved one take the person outside, typically before lunch or before it gets too hot, and to get 10 minutes of sunshine and fresh air, and that can make a dramatic difference. Just by exposure to sunlight, our brain makes more serotonin, which is one of the main neurochemicals that we affect when we give somebody medications. So addressing that is important. Number two, if there is an opportunity or a chance to improve their diet, even if it's just a little bit, because, for example, to have a diet that is high in simple carbohydrates like sugars and the like, it's known to make depressive symptoms worse. It increases chronic inflammation. It can make pain worse. So that is something that we can at least attempt. It's not easy to get people to eat differently once they get older and they have dementia. But we can maybe try to make some perhaps better choices on their behalf.
Yeah,
Something,
yeah, I would think that especially if we speak about people in stages when dementia progresses, their comfort food can be the source of comfort. And now taking that away may not be maybe the first, uh, one of the first steps. Like I get about the sunlight, but just thinking how hard it is for us to change our eating habits. Now, when
yeah.
our cognitive reserve is really small, uh, yeah, and I see you sometimes even just telling people, hey, just let them eat at least something. So what else may be even more effective before even diving into diet, especially in the later stages of dementia?
So I just want to say, yeah, there's a saying that says it's easier for people to change their religion than it is to change their diet. But for example, if the person is living at home and the family is providing the meals, and it may be easier. I'm not saying that it's easy to do, but it may be easier to make some small changes in their diet, which can lead to some improvement in their depression, and also in their cognition, for example. But yes, it's difficult to get young people to change what they eat, let alone somebody who's going through dementia. Some other things is to encourage socialization. And for example, the person with dementia may not want to leave the room, but to make sure that if they're in a facility, that the staff is going to the room and trying to get them out and bring them to activities. Things like music therapy and art therapy are available in some facilities. I think that those things are great. I think that music is a great mood elevator, and that is something that can be done. And we know that socialization also improves cognition. So I think that is like a good bang for the buck, is to do things to increase socialization. For example, if the person is living at home, we have places like, Town Square, Sarasota. We have the Senior Friendship Center, where are places where the families can bring their loved ones, during the day, and they have activities. They can make new friends. And I have heard dozens of testimonials of people who, families of, patients with dementia that were at home and they were not doing well, and they started going to one of these daytime, facilities for people with dementia, and their lives have just improved dramatically. So socialization is a big one. There are, as the people with dementia progress along the path, they become less able to do psychotherapy. But if they are in the earlier stages, if they're at home, there are things like there's some adjustments that can be done to cognitive behavioral therapy that can sometimes be useful. Reminiscence therapy is something that has been shown to work. Something like going for a walk every day.
So
To
I think you're right now kind of running into the next one, but let's differentiate. So it's first, you mentioned sunlight and fresh air. The second one was changing their diet, or at least attempting. Socialization, a big one. Then among the therapists, like psychotherapy may not work in later stages of dementia, but at the beginning, there are psychotherapists that are trained, I would assume, to work with people who have cognitive decline. But also art therapy, music therapy could be effective. And then the last one, exercise, is that physical activity, probably would say.
hmm And I think that some of the best forms of exercise are the ones that are combined with music. So I think that dancing, for example, is something that we know that it elevates mood, but it's one of the most cognitively stimulating and protective activities that we can do. So physical activity has definitely been shown in studies to improve mild to moderate depression. And in somebody with dementia, it can be as simple as just going for a walk, or maybe, if they're in a wheelchair, for example, they can still participate. Like, sometimes in facilities, they have activities where they toss the balloon, and they play like balloon volleyball and things like that. But activities or things that include and encourage physical movement. You know, it's interesting because I think that when I did my training, the pervasive thinking was that you can affect the mind only through the mind. So, what I mean by this is that you could only help people with depression, for example, to get better by medicating them, which works on the mind, or by doing psychotherapy, particularly cognitive behavioral therapy. But I think that we have learned in recent years the importance of physicality, the importance of, and the fact that we can affect how we feel and we think by the way in which we move our body. So if the person is in the earlier stages, uh, something like Tai Chi, Qigong are things that can be really, really effective. And the data supports that. Elderly people who do Tai Chi, for example, they have better mood, they have better cognition, they fall less, and they have better quality of life. So I guess the take-home message is encourage physical activities for the person with dementia and for yourself as well. Like if you're a dementia caregiver and you're taking care of a loved one with dementia, for you to go on a walk every day, for you to take some time to take care of yourself by moving your body is a high yield intervention.
I think also what you're pointing to, what we discovered, or the science discovered in recent years, also the socialization aspect. And when you speak about tossing the ball or doing some activities, or even Tai Chi, which I think in China, you can see people doing that in the streets in
Yes.
groups.
hmm
So even physical activity together with other people probably could be even more effective.
I agree completely. And I go to Town Square and Sarasota, and also to the Senior Friendship Center, and you can see like how the person looks when they come into the facility in the mornings. And they're slow, they're dragging, they look unhappy, their posture is kind of slouched, and they go through the activities, they go through the exercises, they go through the increased socialization, and at the end of the day, they're peppy, they're excited, their posture is more open. In general, they just, their mood is better. So yes, physical movement coupled with music and socialization, to me, that is perfection right there.
And I think everything that you just mentioned also can be a preventative measure against depression in people with dementia.
Absolutely. Yes, 100%. It's
So,
actually like they say, an ounce of prevention is worth a pound of cure. That is absolutely, absolutely right. And again, I want to extend this not just to the person with dementia, but the ones that are caring for them.
yeah, absolutely. 'Cause it's not an easy job. It's not an easy lifestyle.
Oh, for
You
sure.
mentioned
Yes.
you mentioned the second camp, which is medications. So when do you know that, okay, I tried all of this, but maybe it's time to introduce a medication?
Yeah, so we definitely want to give the non-pharmacologic interventions a chance to work. But for example, if those have not worked or they have not worked enough, or if the dementia is severe, like, the person is just truly isolating, they're despondent, they're not eating, they're losing weight, they're refusing to get out of bed, any one of those symptoms, then it's time to consider medications. And so here's the caveat, the take home message for medications: start low, go slow, but go. So start low. Begin at tiny doses of the medications. They should not be given the usual adult dose right off the bat, but to start at a half dose and make sure that the person is tolerating that well. Because, antidepressant medications and psychiatric medications in general are notorious for interacting with other medications and for having significant side effects. And some of these side effects in the elderly can be really important and significant because they're like dizziness, loss of balance and coordination. Um, things that can lead to falls. And that is like one of the things that I always keep in my mind is, if I have to start somebody on a psychiatric medicine, I want to just start really, really low and go slowly, because I know that it doesn't matter which psychiatric medication it is, they have an increased risk for falls in the elderly. So start
Oh.
low, go slow, but go.
Are there any really dangerous interactions with any dementia medications, or especially in your population, that people need to be really careful? I understand that nobody's going to go and get those medications over the counter, so the doctor would be on board making those decisions. But is there something that is like you really need to pay attention to this and be careful?
The first thing that comes to mind is that, for example, acetylcholinesterase inhibitors, the medications like Aricept, Exelon, and Razidine, they can slow down the heart rate and they can affect cardiac muscle contractility. So they can sometimes, in and of themselves, lead to falls. And when you add an antidepressant medication on top of a cholinesterase inhibitor, you need to have that awareness that there is a possibility that the combo of these two medications together can make the likelihood of a fall more, let's say, real.
Mm. And falls, I think we discussed to make next podcast about falls, because falls,
Mhm.
it's not like in younger population. You fell, yeah, you may hurt yourself, you heal, and you keep going. Just recently, we lost a friend who fell and died 2 days later.
Yes. Yeah, falls can be a game changer or a life changer in people with dementia. And their effect transcends and goes way beyond like breaking something. Oh, they broke a hip, or they fractured the femur or the broken arm. Sometimes, they don't have anything wrong with their bones, but the pain from soft tissue injury, from just the rattling in the body, it yeah, it can make a world of difference in somebody. That's why I always try to keep that in my mind at all times. And let me make a little aside here, because I mentioned trying to address or to improve sleep, and this is the tricky part of medications for sleep, and that is, medications for sleep basically by definition make you sleepy, make you drowsy. So if you have a person with dementia who's already unsteady on their feet, and they wake, you give them a medication to help them sleep at night, and they get up to use the bathroom, and next thing you know, you have a fall. So medications are they can be a lifesaver, and I use them a lot. I don't want to say that I am anti-medication, but they need to be used with real caution and awareness, as to not increase the risk of falls in the elderly.
And you're bringing up sleep because you mentioned sleep could affect depression, could bring on depression, poor sleep, or disruption of circadian rhythm. So to first try to get exposure to sunlight or some physical exercise to improve sleep may be much more effective than just giving a sleep medication.
Yeah, for sure. And it's kind of a little bit of like, what came first, the chicken or the egg? Because problems with sleep, in particular initial insomnia, so problems falling asleep, and also what we call early morning awakening. So waking up at 3, 4 o'clock in the morning and then not being able to go to sleep, those are pretty classic symptoms of depression. And I think that it's a little bit of both, that problems with sleep, particularly long term, can definitely make mood worse. But I think also that it goes the other way as well. And that for example, be depressed because of the losses that somebody experiences, loss of independence, loss of dignity, loss of their own physical health, etc., that can maybe lead to depression in the elderly. Like those symptoms then can in their turn also affect sleep.
Yeah, I think that's a very important point. Maybe to conclude, we pointed to that, but to reiterate, what can caregivers do to support themselves? Because caregiving for someone with dementia is not easy. And I can imagine caregiving for someone with dementia and depression may be double difficult. So, what caregivers can do to support themselves?
So, if the caregiver thinks that they need help, they need help, and they probably have needed help for quite some time. You mentioned that perhaps the importance of doing things in a preventative way. I think that my best piece of advice, based on me taking care of my dad who had dementia, and how it affected both me and my mom, who were the primary caregivers. I think that my advice to myself would be, don't wait until you are stressed out and showing symptoms of burnout before you do something. Like, anticipate that caring for someone with dementia is a difficult, taxing job that will most likely affect how you feel, how you sleep, your interactions and relationships with other people, and that things that you can do early on to take care of yourself can make a world of difference. I think that one of the things that we experienced ourselves is that, my mom didn't want to bring caregivers in the home. She thought that we should be able to take care of everything ourselves. And I think that in general, That was a mistake. We looking in retrospect, we should have brought people and tried to access some of the community resources earlier on than we did, and to recognize that we need rest, that we need to take care of ourselves before we can be effective in taking care of somebody else. Having the awareness that so many of the caregivers with taking care of somebody with dementia actually die before the person with dementia does, because the stress is so significant. So making time in the day to take care of yourself is the most important thing. Do not wait until there's trouble, but anticipate that trouble is coming and do what you can to take care of yourself.
I think what you point to, and considering your own experience, the difficulty is maybe even to have an insight that I need help. And I assume, I can't speak, I'm not a caregiver, so by no means I would say I know how it feels. But I assume some isolation and decrease in socialization when the family is going through dementia. And I'm saying family together because it does affect family. I think that withdrawal from maybe being active with friends. And I wonder how much that is important. As you mentioned, on one hand, bringing caregivers, but also tapping into community resources, reaching out to friends. I understand the time constraint is absolutely there. By no means I'm saying, oh, you just can go and hang out with people. But even understanding that having a cup of coffee with your friends somewhere outside of the house for even 30 minutes could make a difference.
Oh, totally. And you bring up such a good point, because one of the things that can really be helpful is to join a support group. And I would say that here, most facilities have a support group that meets on a regular basis. The Senior Friendship Center, for example, is one of my favorite places to send people for support, and it can make a big, big difference. We mentioned exercise and physical activity, making sure that you go on a walk, every day. If you enjoy going to the gym, do that. If you like, playing tennis or doing aerobics or going for a bike ride, to make exercise a part of your daily life. It'll help you sleep better at night. It definitely, gives us a better sense of well-being. It improves our quality of life. It improves depression. It helps cognition. I mean, so many things that can be helped by physical activity. And I want to quickly interject a little bit here that the diet, I mean, again, is something that is important. And I think that in my experience, when my mom and I were in the thick of it and we were stressed out and not doing particularly well, I can tell you that my dietary choices actually worsened. you know, I definitely, was just making much more comfort foods and things that were not necessarily that good for me. And the tricky part about making those less than stellar food choices is that that increases inflammation in our body, which actually makes us feel worse. We get more aches and pains, our joints hurt, we can have some brain fog, we're not thinking as clearly, and it can definitely make symptoms of depression worse. So what we put in our body is definitely important.
Also as someone who went through an eating disorder and familiar with depressive states, what I hear is also, it's so important to make those choices with the loving compassion for yourself. Because once we're stressed, like you were, and then there's another hammering thought, I have to eat better, why I'm not eating better, I have to exercise. And we just watched the show Clowns Like Me by this guy Scott, who lives with mental illness. bipolar, depression, OCD, some autism. And I think he was making such a good point that sometimes it's not even the symptoms of those conditions, but the isolation and loneliness that's really hard. And when we met with some caregivers, I think I get that sense from them because there is still a bit of stigma around dementia, or it feels like they're in their own world and they're alone. And to just remind yourself that you're not alone. And yes, it's hard, but to reach out to support group, maybe do physical activity with the people you enjoy doing physical activity with. Even if it's going to the gym, set up a group, going to the gym or doing your bike ride. If it's eating a healthier salad, maybe also together with some other people. Because there is, I think, more and more stories of data going that losing connections with others can really affect our mental health. And I think it's the case with people who have dementia, and for sure the case for caregivers. And compounding anything medically we can do. Like medically, I mean physiologically, diet, exercise, sunshine, and bring social aspect to that can, I think, be really beneficial. Because when we go through hard times, our tendency in all of us is to withdraw. And the biggest thing sometimes we could do is not to withdraw, but to reach out for help.
Yeah, I mean, that is such a good point. And yeah, it's so tricky to tell ourselves, oh, I should be doing this or I should be doing that. And yeah, to open up in our to our own life, to maybe have that recognition of our struggle can help us to take care of ourselves a little bit better. I think that there's a lot of shame involved in dementia caregiving. Like for example, it is not unusual or unheard of that the caregiver may get angry with the person with dementia. That the levels of frustration may be sky high sometimes. I mean, I know that my mom and I definitely went through that, and I hear it so much from my families that they are losing patience with their loved ones, and then that in turn makes them feel guilty. It makes them feel upset with themselves. So yes, I mean, I think you bring such a good point that our ability to be gentle with ourselves, our ability to be compassionate with ourselves is the most important thing. I mean, these are ideas and things that you can do, but the not doing them should not this that should, but to not do them hopefully will not be a way in which we beat ourselves up, because that kind of defeats the purpose. So these are things that, just tiny steps. I don't go on a 3-mile walk the first day. Just walk to the end of the street and back. Just little tiny things, can have big lasting changes long term.
So be gentle to yourself, invite friends for your walk, and I think it's a good place to end this podcast. Thank you so much for listening. If you have any suggestions or questions, please reach out to us, leave them in the comments below, and we'll see you in the next episode.
Thanks for watching.